Let's say you have 100 BRCA1 patients, 78% actually have triple-negative breast cancer.
So staging means very different than grading.
You mentioned a CT scan and a bone scan. At what point would PET-CT actually be relevant to the process?
Introducing the most aggressive breast cancer subtype, triple negative, in this first episode of this Health Chat series. More episodes are coming up shortly. Keep tuning in by subscribing Talk Health Asia's YouTube channel.
We are discussing triple-negative breast cancer tonight. With me, Prof Dato Yip Cheng Har of Subang Jaya Medical Center and Dr. Nina from UMC just joined us. We asked that the questions be kept just to triple-negative. What is triple-negative breast cancer? Can you explain that to us a little bit?
Triple-negative breast cancer, or also TNBC, is cancer where your estrogen receptor, progesterone receptor, and the HER2, which is human epidermal growth receptor 2, is negative. If you look at this slide, this is a pathology slide. This first panel here is the ER/PR positive, HER2 negative. The last one is triple negative. If it stains positive, like you look at this brown staining is positive, it's brown, then it's positive. If you look at this triple negative breast cancer, there's no staining at all. And that's how the pathologist in the report will say that you have ER/PR HER2 negative or triple negative breast cancer. So this is diagnosed in the lab by the pathologist.
And how is triple negative breast cancer different for the patient compared to other subtypes of breast cancer like hormone positive and HER2 negative?
Well, TNBC is considered to be the breast cancer with the poorest prognosis. It is associated with more aggressive features such as young age, grade 3, which is the highest grade, and also more likely to present with later stages since it grows faster than the other cancers. And you can see this in Kim's story. You know, she is young and her cancer grew very fast. And so that's a sign of triple negative. This slide shows survival according to subtypes. So the top line is the ER positive, PR positive, HER2 negative, and the bottom line is the triple negative breast cancer. This is a paper that we published from the University of Malaysia Medical Center. And you see all the 4 subtypes and the 5-year survival of breast cancer. If you look at the ER, PR, HER2 negative, is 74.4%. This is stage 1, 2, 3. Okay, we are not looking at the stage 4 triple negative breast cancers. And it's similar to the ER negative, PR negative, HER2 positive subtype. But this paper was done in the time when people had very little access to Herceptin. So if you have Herceptin, the ER negative, PR negative, HER2 positive subtype actually has a better survival than this 75.1%. So triple negative breast cancer is associated with poorer survival. And also, it is more likely to be associated with BRCA1. So this is a paper that is also done locally. We do a lot of studies on breast cancer. And this one, we do a lot of work with Cancer Research Malaysia. So this is an Asian series of 110 triple-negative breast cancers. 24.5% have a germline mutation of BRCA1. We'll be talking about genetic mutations later on, I think. BRCA1, yes. BRCA2 is the 2 commonest mutations that you find in breast cancer. You see, in triple-negative breast cancer, about 25% have BRCA1 and BRCA2. But if you look at the other patients with different types of breast cancer, you know, patients with breast cancer, that means all types. Out of 2,575 patients, 121, only about 4.7% were BRCA1 and BRCA2 positive. You know, so you can see the difference. If you have triple-negative breast cancer, you're actually 5 times more likely to have a BRCA1 or BRCA2 mutation compared to the other types of breast cancer. You look at the normal women, those without breast cancer, only 0.4% have BRCA1 and BRCA2 mutations. This is a paper that we also did from Malaysia. We look at all the blood samples from over a few thousand women that was recruited from the University Malaysia Medical Center as well as the Subang Jaya Medical Center. So, okay, this is it. So when you look at all the BRCA patients, BRCA1, okay, BRCA1, let's say you have 100 BRCA1 patients, 78% actually have triple-negative breast cancer. BRCA2 is different. BRCA2, BRCA2 is like any other breast cancer. That means you can have hormone positive hormone receptor positive breast cancer, you can have HER2 positive breast cancer. The BRCA2 can be any type, but the BRCA1 specifically is usually triple negative breast cancer. So these are how triple negative breast cancer is different from the other subtypes.
Dr. Nina, what is the survival rate for 5 years and 10 years for triple negative breast cancer? And in that sense, is staging and grading even relevant?
I think it's really, really tricky trying to discuss prognosis or sort of life expectancy of patients. However, I think that's really the crux of the matter. A lot of participants here have submitted questions, and even just now I was sort of chatting through. A lot of them really do want to know about survival, because in triple negative breast cancer, we talk about aggressiveness of the cancer. However, I think we must remember a couple of things when we talk about life expectancy. Number one, that's statistics in terms of, if we talk about 5-year overall survival, what does that mean? That means from diagnosis. So when you're diagnosed with breast cancer, and then we follow patients up through to 5 years, and we look at the percentages of patients who survive or who is alive at 5 years. But that's a number, and you talking about the woman or participant here, you're an individual. So everyone's an individual going through different journey. So I feel that we shouldn't fixate. With that being said, I think Prof Yip has already mentioned in terms of the 5-year overall survival at about 75% for patients with triple negative breast cancer. Right. Just touching on your staging versus grading. So staging means very different than grading. Staging really, in the basic terms, mean the extent of the cancer. Has my cancer spread to other parts, right? From my breast to my lymph node or to other parts of my body? And how do we know that? We try our best, and that way, to do that, we usually do scans. So that would involve, for example, CT scan to assess and bone scan. Whereas grading really look at the cell. So when you take your cancer cell and you look at it under the microscope, and that's being done by medical doctors called pathologists, and they look under the microscope, what they're trying to assess is how different or how similar it looks to a normal breast cell. So if it looks more different, then we put it as grade 3 or higher grade. If it looks similar, then it's a lower grade or tamer. So what we want to do, whether they're tamer or more aggressive. So more aggressive is grade 3, whereas tamer is grade 1. And we use all these factors, not just one, to then discuss or understand more about your cancer and then tailor the treatment for you.
Thank you for that, Dr. Nina. I think you explained grading very clearly, and I appreciate that. We tried to cover that in 101, but we were not able to go into the depth of it. Bringing you back to staging, you mentioned a CT scan and a bone scan. At what point would PET-CT actually be relevant to the process?
Okay, I think so if we look back at how medical care was done, usually as a standard, we would do CT scan and bone scan, and that's absolutely standard practice. PET-CT has not come into as standard practice. However, when it is available, some surgeons and oncologists do want to request a PET-CT scan. So PET-CT scan is different than a CT scan in the sense that it's a functional scan. It shows which parts of your body takes up glucose more. So when you look at PET-CT scan, you see that your brain comes up as red. And I always tell my patients, hey, hang on, that's normal. That doesn't mean that all the cancer has gone to your brain. So right. It gives us a different information which we can put and piece together to understand more about your cancer.
I see. Coming back to you, Dr. Yip, Dr. Nina has spoken to us a little bit in terms of, every woman is an individual. We shouldn't really wholly rely on statistics, right? I mean, we could be on any end on the spectrum of statistics. What are the chances of a woman being triple negative?
Well, this is also a very interesting research that I've been doing when I was in UMMC, because I have a database and we just collect data. So this is a paper we published. Out of 1,957 cases of breast cancer that we saw, 19.6% were triple negative. And this is the usual percentage that is reported in other places. But if you look at the paper from Kuching, Sarawak, this is also done locally by Dr. Bina Devi, who was an oncologist there. The triple negative rate was 29%. And this is because in Sarawak, you have the natives. The natives have a higher incidence of triple negative breast cancer. Even in USA, the Black Americans have a higher incidence. So sometimes it's ethnicity, which is one of the factors for triple negative. I also looked at triple negative among our three races, Malays, Chinese, Indians. We found that it was the same. It wasn't like any race was more likely to be triple negative. Whereas, in some races like the Africans and also the natives in Sarawak, is more likely to be triple negative, sometimes even up to over 25 to 30%.
Dr. Yip, what sort of tests, would a woman have to do to get there? We discussed this briefly in the 101, but it would be so helpful to us if you could walk us through that journey again.
Okay, so how do we diagnose triple negative breast cancer? Like I said, it's diagnosed in the lab on the tissue sample using this technique called immunohistochemistry in the lab. They use special test kits that will stain the tumor tissue. It's not a test that you can do in the blood. It's not that you cannot see it in the mammogram or ultrasound. It is in the tissue. I have patients whose tissue biopsy was done elsewhere, and they say, can you do the test to show whether I'm triple, to show my HER2? I say, I cannot test it in your blood. I need the tissue, and I don't want to take any more tissue from you, because the biopsy specimen that you can do elsewhere is kept in the lab for many years. And I think the standard is like 25 years. So your tissue will always be there. They don't throw your tissue away. So you can do this immunohistochemistry test on the biopsy specimen. Okay, so as I said, if there's no staining seen, it is triple negative breast cancer. The degree of staining is important, because ER can be 10%, or even 1%, or it can be 95%, but it's still positive. But if it's 1 to 9%, it's low positive, and it might be almost like triple negative. HER2 in the same way can be equivocal. One woman said her HER2 was equivocal, but then it became triple negative. You see, when HER2 is equivocal, the pathologist report it as 2+. If it's 0 and 1+ is negative, 3+ is positive, 2+ is neither here nor there. So I look at the data, almost 25% of our tissues are HER2 2+. And this one you have to do FISH test. And my patients get very upset when I say you need to do FISH, because FISH costs 1,200 ringgit. And they have to pay this 1,200 ringgit just to know whether their HER2 is positive or not. So there are many types of FISH. I mean, it's not just FISH, it's actually called in situ hybridization. So you have FISH, CISH, SISH, DDISH, but whatever it is the ISH, which is important. So this FISH is the commonest done, will determine whether your HER2 is negative or positive. This is how the test to diagnose triple negative breast cancer is made. So you need a very good pathology lab. I always say that the most important person in your treatment is not the surgeon or the oncologist. Sorry, Nina, but actually it's the pathologist. I'm sure we all agree that the pathologist is king. Based on his pathology report,
conclusion,
your whole fate is sealed.
Right. I want to bring you back to a little bit what you said. I appreciate that you talked about the staining, but you mentioned that the staining is done in the lab and from a tissue extracted. How is that tissue extracted, and what sort of biopsy? Should patients be going for a surgical excision biopsy? There are people who have never had breast cancer awareness before. So I just want to bring us back with the biopsy. When you say extract the tissue, what sort of biopsy should women be doing?
Usually, the ideal biopsy is a core needle biopsy, which uses a little needle to take out tissue. You can also have fine needle biopsy, but nowadays fine needle biopsy is hardly done, but it's cheaper. We don't do excision biopsy because I always say that if you do excision biopsy, you lose a lot of very valuable information. You went to a general surgeon, you just want to take out your lump. That's an excision biopsy. But if it takes out your lump, you lose a lot of opportunities. You lose the opportunity to have neoadjuvant chemotherapy because your lump is out. If your lump is small, you lose the opportunity to do sentinel lymph node biopsy, where you really do actually sometimes need the lump there. And you also lose the opportunity to do intraoperative radiotherapy if you have a very early small cancer. So if you do excision biopsy, there are 3 things that you will lose the opportunity to do.
Thank you for that, Dr. Yip. So to recap, we should be looking at a core needle biopsy to extract that tissue, and then that is sent to the lab for staining.
But I have to also explain to you that some patients are terrified of a needle biopsy. I find that a lot of patients think that putting a needle into your tissue is going to cause the cancer to spread. I'm sure we've come across that, isn't it, Nina? Oh, so many patients just refuse to do a core needle biopsy. But I always tell them, all over the world, we do core needle biopsies to diagnose cancer. If what you say is true, that core needle biopsy caused the cancer to spread, all the women will have died, isn't it? Those who have breast cancer.
I'm glad you debunked that myth. Let's go back even further, where you talked about BRCA, right? BRCA1, such a high percentage in TNBC. Dr. Nina, can I ask you to explain to us, especially for a lot of general public members here, what is BRCA?
I think we have to take a lot of steps back and first ask ourselves, what is BRCA? So BRCA is really breast cancer gene that lives in your cells. So your cells are very clever things. It has DNA that tells the whole body all the information, and it's all packed up in the nucleus. And so BRCA gene is one of the genes that lives in there. And it's a tumor suppressor gene. So it does exactly that. It suppresses tumor from forming. So when your BRCA gene is mutated or deleted, then it cannot do its job properly, and it cannot suppresses tumor from forming. So you do get tumor formation because of BRCA. So that's what BRCA gene is.
Before we go into the testing, right? So we are trying to test whether a woman has BRCA. But the question is, I think, Dr. Yip, who should be doing this sort of BRCA testing?
Well, if you look at the criteria, this is the Malaysian Clinical Practice Guidelines. Let's just look at triple-negative breast cancer. All triple-negative breast cancer diagnosed less than 60 years old should have a BRCA test done. Okay, this is the guideline. And if you look at the other criteria, ovarian cancer, because ovarian and breast cancer are both related to the BRCA1 and 2 gene. Breast cancer in patients less than 45 years old, 2 primary breast cancer, both diagnosed less than 60 years old. That means you have cancer on the right and they have cancer on the left, So bilateral breast cancer is more likely to be BRCA, and male breast cancer, yes, and then number 6, it went there, is breast cancer plus a parent, sibling, or child with any of the above criteria. That means you have breast cancer and your mother or your sister also have breast cancer, then you are more likely to have a mutation in the family. So these are all the criteria for genetic counseling and testing. Before testing, it's very important to have counseling, and we now have genetic counselors. But because of the shortage of genetic counselors, a lot of clinicians actually do the genetic counseling themselves, and that's called mainstreaming of genetic counseling and testing. And if you do a proper genetic counseling, you have to tell them all the pros and cons of testing, because now genetic tests, there's BRCA, we will talk about this later. This is called focused treatment. If you are BRCA positive, then there's a different treatment for you. I think
Right.
Nina will probably talk more about that.
Yeah, let's go into that, right? So how if a patient already knows she has breast cancer, why go for this BRCA testing? How does it help the patient?
For so many reasons, but I think what I face in my clinic is, Pauline, usually I'm faced with ladies who are battling the diagnosis to begin with. So there's a lot to take in at that moment where you hear the word cancer, then you're thinking, all these treatments that you have to go through, for example, chemotherapy and then surgery, then you have radiotherapy. So you are absolutely overwhelmed. And I find that it makes it very tricky for patients to make such decisions in terms of genetic screening at the early part of their diagnosis. However, genetic screening as such, knowing whether you are BRCA positive or not, does help us, your treating doctors, make more treatment plan, individualized treatment plan for you. So, for example, if you have BRCA positive and you have early breast cancer that has not spread to other parts of your body, or perhaps it's just spread to lymph nodes only, which means that you can undergo curative intent treatment, then there is a chance that we can give a further treatment, which is tablet treatment to consolidate. So meaning the BRCA gene testing will help tailor your treatment for you. So that's one main reason why you want to have those tests. Another reason is because clearly then you want to think, hey, does it increase my risk of other cancers? So yes, it does increase your risk of the contralateral breast. So for example, if you have breast cancer on one side, you might get increased risk breast cancer. The other side, you might get increased risk of ovarian cancer, for example. And if that is the case, then you might want to discuss in terms of prophylactic or surgery to reduce or minimize those risks. So the earlier you do your BRCA gene testing, then the earlier we can plan all this treatment. I'm just going to insert neoadjuvant chemotherapy there. So,
okay.
So big words.
You might have to unpack what neoadjuvant means.
Absolutely, big words. So neoadjuvant literally means chemotherapy given upfront before surgery. We will discuss a little bit more about that, but what it literally means is when you're going through your chemotherapy. So usually in the traditional sense, we treat breast cancer with surgery first, and then we give chemotherapy after, and that's called adjuvant chemotherapy. But now, more and more, we are giving upfront chemotherapy, and then we have surgery. One of the advantages of that is it gives that time for the patient and the family to digest information in terms of their diagnosis, and then make a decision about the genetic testing, and then wait for the genetic testing result and plan appropriate surgery or surgeries for the patient if the patient has BRCA positive. So those are the reasons why we would advocate for BRCA testing. Clearly, other reasons include your beloved family members in terms of if they could also go for early screening if you have BRCA positive.
You've mentioned, just to follow off through what you just said, that is whether your beloved family members would also be a carrier of the BRCA gene. One of the questions that was submitted by our audience was this: if members also have BRCA1, should they be encouraged to do prophylactic surgery, preventive surgery to remove the breast?
Definitely. We have actually done prophylactic surgery for family members of breast cancer patients who are BRCA positive. But again, it's a very big decision to make, like when do you do it? I mean, the most famous example of prophylactic surgery is Angelina Jolie. In fact, when she had a BRCA1 mutation, she does not have breast cancer. So what she did was she had both her breasts removed and she had breast reconstruction done. And later on, a few years later, she had her ovaries removed as well. And this is what we do as well, except that we don't have many patients who actually agree to it, Even patients who are BRCA positive, ideally, they should have both breasts removed. But it's a bit too much for them to take in. So usually we actually only treat the cancer, the breast with the cancer and not the opposite breast. And we monitor the opposite breast very well. And it is this monitoring which is difficult. I've had BRCA patients where you can monitor like mad, but they still get diagnosed with stage 2 breast cancer somehow. I don't know why, because, somehow patients are not very good about surveillance sometimes because, again, like Kim says, it's actually maybe in a way denial, don't want to know.
Yeah. And I have a silly question for Dr. Nina, actually. Is BRCA test a once-off test that you do in your lifetime, or something that you have to repeat? Does it change?
I love silly questions because I think sometimes they're probably the cleverest question of all. So the short answer is you do it once in a lifetime, but whenever we send our ladies for genetic testing, you don't just test for BRCA alone. Usually it's a panel of different genes that can increase your risk of breast cancer. So for example, in Cancer Research Malaysia, based in SGMC, where patients go for genetic counseling, they usually do a 19 gene panel test for other genes. So if in the future, for example, with medical advancement and research, if there's new genes that come up that shows higher risk of breast cancer, maybe then, in the future, you would want to test for those genes that were not tested before.
That's helpful to know. Is genetic test covered by insurance, or do we need to self-pay?
I think I've kind of answered that most of the time it's self-pay. I've not heard insurance paying for the genetic testing. Right, Prof Yip?
Yeah, no, the insurance do not pay for it.
And another submission was given, I'm triple negative breast cancer, androgen 85% positive, BRCA1 and BRCA2 also negative. Is that androgen a kind of hormonal cancer?
It's the oncologist that's asked for androgen receptor.
We don't routinely ask for androgen receptor positivity in breast cancer. So I think when she has triple negative breast cancer, I don't think that would change the management for the patient.
I see. Next question. Can BRCA testing be done amidst and between targeted therapy, because I have not yet done the BRCA testing?
I mean, absolutely. It can be done at any point of your journey. The earlier, the better. But yeah, at any point.
Great. Next question, back to insurance. If I'm BRCA 1 and 2, will it affect my purchase of insurance for my daughter in the future? I think that's a tricky one.
Sorry, this one is a confidential information. Insurance companies do not have access to the information. I don't think we have to disclose. That's why a lot of patients don't want to test, because they are worried about the insurance issue,
Okay. Last one for BRCA. I was diagnosed with TNBC in April 2023, 64 years old, Chinese. No family members diagnosed with cancer below 60. How useful is a BRCA test in my case? Based on what the doctors are saying, I assume it is useful anyway. Would that be right? She's 64 this year.
That doesn't really meet the criteria for genetic testing.
Okay. All right.
Oh, can we give a little bit of immunotherapy for our patients?
How is it that the breast surgeon and oncologists are taking different views in my case?
Is lumpectomy recommended for young patients in their 20s?
Subscribe to Health Asia's YouTube channel for more health chats episodes, or find easy to understand health videos on talkhealthasia.com.